TV USA. Οι δραστηριότητες της ελληνοαμερικανικής κοινότητας με βίντεο και πλήρες ρεπορτάζ.
Great speakers and all the work that goes into putting an event like this on. I don't know if everybody appreciates the amount of time spent above and beyond her profession for something like this. So Stella, I thank you. We do, however, all appreciate Evangelia, our administrator, for always putting the time and going above and beyond. So Evangelia, I thank you. A quick introduction to the Medical Society. Our job, or our main push, is for scholarships for medical students. So if you have somebody that you are aware of that is a candidate or an appropriate person for such a thing, don't forget about us. The monies are there, but also the recognition is there, and that's really our major push. Our next big event, of course, is the Papa Nicolau seminar, which will be in a month from now, and you'll hear more about that. In lieu of that, one of the sponsors of the parade is Lenox Hill Hospital, and this would not be without the help of our distinguished Helene 2016, who is here tonight, Mr. Gus Costales. Come on up and give us just a 30-second pitch about Lenox Hill, and not to steal his thunder, but as a person who uses a lot of the doctors here at Lenox Hill, and perhaps we can convert some of the doctors in the audience to come to Lenox Hill.
That's why we're here.
That's why we're here. But as a person who is in the community and uses the other doctors, and who's had the luck and good graces to have come into contact with somebody like you, I can say that I don't know how the non-Greeks do it, but the Greeks at Lenox Hill are very well supported, if nothing else, from this guy alone. And it's a wonderful team that I am happy to contribute to and be a part of. And that Lenox Hill sponsors something like the parade when they don't have to is a wonderful thing.
Again, you all have been tremendous supporters, not only of Lenox Hill, but of our community of patients and families. And again, thank you for everything you do. You're a part of our family too, so thanks again. Lenox Hill Hospital would love to thank you and welcome you here tonight. As always, the Hellenic Medical Society has had tremendous history here at Lenox Hill. I've come to, this is my 15th event here over the last 7 years, and they've always been phenomenal. Dr. THEODOULOU, you're amazing. You really are an amazing woman. And I saw her on the schedule today. Great job, by the way. And I said, I have to be here tonight. And she is a phenomenal woman. She saves a lot of lives, saved a lot of lives, people that I know, and proud to know her and blessed to know you.
Without further ado, Dr. Limberis.
This is our 7th annual Medical Pathakis Distinguished Female Symposium. And Maria THEODOULOU was there for our first symposium 7 years ago at Memorial Sloan Kettering Cancer Center. And you know, it's really a privilege to have the opportunity to honor the achievement of women in medicine, and historically by the Hellenic Medical Society. Now we invite only female speakers to speak, and each year we have an extraordinary female who has really spent her whole career in medicine, and it's really a testament on the abilities of women in this field and their unique sort of perspectives that they add to medicine that we want to feature with our Hellenic heritage. Mary Kalopathakis was born in Athens in 1859. and was the daughter of Michael Kalopathakis, a doctor in Athens, and Martha Hooper Blackler from Marblehead, Massachusetts. We think she's the first physician to practice in Greece. We're not sure. There may have been one other physician earlier who studied also in Paris. She studied in Paris because the Greek medical schools were not open to women at the time. She returned in Athens and practiced in pediatrics and gynecology and also surgery at the front for the Greco-Turkish War of 1897. We are very proud of the heritage of women in medicine, and just to add a personal touch, I'm very excited to introduce Katerina Raptis is going to come and speak and also give the introduction for Maria, since she knows her personally and was her patient. So we're very excited to introduce Katerina. Thank you.
Good evening, honorees, physicians, and guests. I'm extremely honored and humbled to be here this evening to introduce an extraordinary woman. For 22 years, breast cancer oncologist and attending physician, Dr. Maria THEODOULOU HABER, made her mark at Memorial Sloan Kettering Cancer Center. She was an active participant in clinical trials for chemo prevention, understanding defining the heterogeneity of breast cancer, initiating new pathways for treating hereditary breast cancer, triple-negative breast cancer, HER2, and endocrine refractory hormone receptor positive breast cancer. She was also a professor of medicine at Weill Medical College of Cornell University. Dr. THEODOULOU worked tirelessly to help countless women battle a disease. Currently an attending physician at New York Oncology Hematology in Albany, New York, she continues to provide so many women and the help they need to fight. A daughter, sister, wife, mother, and now breast cancer survivor. I was diagnosed nearly 5 years ago at the age of 32. For the past 5 years, Dr. THEODOULOU made her mark on me too. I am here today before you because of my team of doctors led by Dr. THEODOULOU. I clearly remember the day I was given the news that I had breast cancer. I sat with my husband, my 2-year-old son, and my family and felt the earth beneath my feet crumble. My life would never be the same, I told myself. I will never be the same. At that moment, I promised myself that I would battle the disease with everything I had. My family and my team made sure I was the best doctors and let me choose who I was going to hold my hand through this battle. When I first met Dr. Theo, I felt as if I found my angel. Her patience, professionalism, and sheer determination to give me all the necessary tools to fight the aggressive cancer that I had were evident from day one. She took me under her wing, and from that moment, I knew she would be the one and be with me every step of this journey. On my worst days, she would say to me, "You will hate me now, but love me someday." And she was right. She did everything in her power to save me and make me well again. Tonight, I stand before you cancer-free. I am proud to say that I'm a breast cancer survivor. My life has clarity. I have never, ever take one day on this earth for granted. This is why my family and I started the Cat's Ribbon of Hope Foundation. I wanted to give back to help other women who cannot help themselves and to provide funding to incredible research like Dr. THEODOULOU's. In fact, Dr. THEODOULOU was our first honoree 4 years ago. And here I am, 5 years later, introducing to you my hero. She is and always will be my breath of fresh air. I am forever grateful and blessed that you came into my life. My wish for you is that you continue to help so many women to live, that one day, someday, you will help us find a cure. Please join me in welcoming a true warrior, a heroine in breast cancer oncology, my angel and the angel of so many women, Dr. Maria THEODOULOU.
So how does one follow that? I'm not sure. I think we have to take a leap of faith right now and really truly believe in the bottom of our hearts that one day I will be out of work because there won't be a need for someone like me. I want to just say two things before I jump into this lecture. 35 years ago, I was a recipient of a grant from the Hellenic Medical Society. And I don't know if some of you young'uns know that. And it really kick-started my ability to move forward with an education with my young daughter. Forever grateful. And thank you, Stella. Thank you, George. Where's Evangelia? Evangelia, you are the Hellenic Medical Society. And certainly thank you for the nominating committee and having me be here tonight. It's really more than you could ever imagine. And Katerina, you're not just a breast cancer survivor, you're not just a daughter and a mother and a sister and a wife. You are a true hero because you worked tirelessly throughout the year trying to figure out how you can give the advantages that you think that you had to other women who may not have the education, the means, the funds, the navigational issues to get them to where they have to go to. You are helping and saving so many women. You don't have to be an MD, a PhD, or a researcher. You really are doing God's work, and I'm very, very proud of you, proud to know you, proud to be part of your life. When I thought about what we were going to talk about tonight, and breast cancer is such a huge arena, and it really takes days and days and days just to introduce all of the potential topics for discussion, because breast cancer is not one disease. It's never been one disease. We call it breast cancer, but we're too lazy to change the nomenclature. It's multiple diseases under one umbrella, and it behaves very, very differently depending on the host that it affects. And we know now that there's so much more that we need to understand, but I can tell you at a time when all I used was chemotherapy and a very narrow armory of drugs in order to treat patients who I unfortunately visited their funerals multiple times during the year. The mortality has decreased, and I want you to remember that during this lecture, because we will be talking about advanced disease. That's where we make our strides. That's where research actually moves forward in order to help patients who are diagnosed with early breast cancer. The mortality has decreased. There are women living today that might not have 3 decades ago and 2 decades ago. It's become such a treatable disease, and we haven't quite gotten there, but we are making tremendous strides. We're going to focus on hormone-sensitive breast cancer because for all of the banter about triple-negative disease and HER2/neu overexpressing breast cancer, what we're going to talk about this evening is how all of this is hormone-sensitive related disease. And we started the movement very, very slowly. We are actually now not just walking and running, but we are leaping and moving forward to new horizons. These are my disclosures. None of them affect the talk for tonight. Everybody who comes in, just sit down. I'm not distractible. I'm a grandmother. You can interrupt me. There are going to be 400,000 breast cancer-related deaths around the world this year. And if you do the math, and some of you are going to do it very quickly, it is as many victims as we lost at the World Trade collapse, dying daily around the world from breast cancer-related issues. 1,400,000 cases. In this country alone, there are going to be about 240,000 cases with an expected death rate annually in this country of about 40 to 45,000 deaths, depending on which SEER analysis you're looking at. It is the second leading cause of mortality in women from cancer, lung cancer being the first. But if we look at women who are in the 44 to 55-year age group, and think about that age group where we are not only productive, we have reached our maturity in our microenvironment, in our macroenvironment, in our community, in our professions, in how we're raising our children. We're coming into our own on numerous levels. It is the #1 cause of cancer-related deaths in that young age group. Think about how expensive those years are. 1% of breast cancers are found in men. I had 2 men come to me just in the past 1 month. and we often forget about it. And they usually come to me when it's advanced because if they're widowers or if they're not living with a woman who's up to date with what's going on the talk shows or in journals or listening to their neighbors, they don't pay attention to that quote-unquote boil that may be growing on their breast wall. But it's still a disease of women who are middle-aged, and 50% of cases are diagnosed in women 65 or older. Now, I take exception to 65 being considered elderly today. I think we hit middle age when we're healthy in our mid-80s. We're living a long time. Women in this country, their median age today is about 94, so we have lots of years to develop breast cancer. And if we look at the general population, 12% of women are going to develop breast cancer in this country. 12%. 12%. So if you have a wedding party and you have 100 couples, and there are 100 women there, 12 of those women in that wedding party are going to develop breast cancer. That's huge. That's huge. And we need to be able to understand why that is happening, because we can blame genetics, we can blame environment, but we really don't know what to blame. What I'd like to be able to get out of tonight is to talk to you a little bit about the molecular biology of hormone receptor positive breast cancer, try to understand the mechanism of action of our cellular mutations that contribute to metastatic disease, and how we're targeting these actionable mutations and refocusing our treatment strategies. Breast cancer is an old story, and if you've heard me speak, I always present my talks with this slide. I don't think you can see it well with all the lights we have on. But if you look at this area right here, all right, this area right here, and I'm happy to show it to you on the laptop at the end of the talk. This is a painting by Rembrandt. It was completed in 1654. He was painting his mistress posing at Bathsheba at her baths, and she's hanging in the Renaissance wing of the Louvre Museum. And if you do happen to go and look for this painting, it's absolutely astounding. And although she looks quite voluptuous, if we look very carefully, those are huge lymph nodes under her armpit. And that blush that we see in her breast is actually a locally advanced breast cancer. This is not a new disease. This is a disease that was documented 3,000 years ago by the Egyptians in a male, not a female. So what is breast cancer? For a long time, for a long time we would look at the duct and we would say, all right, we have a lining of cells. One becomes abnormal if there are enough genetic mutations and it starts to develop the ability to proliferate, and it doesn't know the checkpoints to be able to be taken out by our own immune system. We wind up with a ductal carcinoma in situ. It has not broken through the wall. Once these cells have the ability to convert this epithelial membrane to a mesenchymal membrane, you have leakage of these cells. There are blood vessels, there are lymphatic channels, there are nerves, all there to provide nutrition and good health to those milk glands, and certainly an avenue for these cells to seep into. There is no organ that is not vulnerable to these cells moving there. But it's not just that simple cartoon. We know now that it's much, much more, and there are acquired functional capabilities of these cancer cells that develop as breast cancer progresses. The hallmarks of cancer, most of us here know this. We've all studied it in medical school and further down the line. And we know that as these benign proliferative changes change, they respond to growth factors and a failure to respond to apoptotic signals. What are apoptotic signals? It's the natural cell death of a cell that is old, senescent, or abnormal. Our immune system is designed to take out these cancer cells. And George is going to hate this, but I'm going to ask him to come to the podium just for a moment. Yep. This fine specimen of a male who's wearing a gorgeous pink shirt and a fabulous tie. All right, here he is. His mom is very proud of him. If I were to take all of the genetic material that's found in every cell that makes up every tissue, that makes up every organ, that makes up this George as we see him right now. Now think about all of the base pairs that are found on one chromosome, the material that wraps around tightly to develop a chromatid. If I took all those base pairs and I stood them head on head, it would be 7 round trips from the Earth to the Sun. think about all of the places where something can go wrong. But our immune system has the capability, and we're structured in such a way that when things go wrong, and they go wrong all the time, there are checkpoints, and there are inflammatory components, and there are cells that are a part of our immune system that get rid of these cells. Obviously, something goes wrong somewhere in this whole spectrum. Thank you, George. Thank you for coming up here. I'll probably have you come up again. But something does go wrong, and something goes wrong in the ability of these cells to be taken out, and we now are beginning to understand that our immune system actually starts working for the tumor cells instead of for us. And what is it that incites that? So we know that the invasive carcinoma is also dependent on what happens in the environment. I could have the identical tumor size, the same axillary metastases or no lymph nodes in a patient. I could have the exact same age patient, same hair coloring. The pathology looks identical from two patients under the microscope, and yet in one patient, that'll be the end of it after surgery, but in another, it won't. What is it about our own systems? What is it about that fertile soil that we have that may enrich these seeds to move away? Think about just a packet of seeds that we throw into our garden. They're either going to settle in the soil and germinate based on the climate, the pH, the acid-base balances, whatever water levels we have, whatever the temperature is, and nothing may happen. In other places, it can germinate and sprout through the ground and throw off weeds with seeds. It's not that different when we try to do the comparison with what happens in cancer. We know that there are key biomarkers in breast cancer, and if we look at the cell, we know that the estrogen and progesterone overexpression has always been the target from the late 1800s up until what's moving forward in the future. These are not only predictive markers, but they're also prognostic markers. And we look at the histology, we try to see if the cancer is coming from the duct of the milk gland, where the milk exits, or if it's coming from the lobule, where the milk is created. And we look at these pathways, and we try to understand what is it about these pathways that can develop into a breast cancer. We know that estrogen that's circulating, estradiol that's circulating in the periphery, richly so in premenopausal patients. Certainly we, in our postmenopausal setting, are still making estradiols. They're usually from conversions of androgens. They're usually from conversions of steroids that are made in other organs by enzymes into estradiols. And we know that there is a coupling of estradiol with a receptor that sits inside of the cell. And once that coupling occurs, it activates all of the RNA synthesis. Certainly CDK4/6 matches up to cyclin D, and we have phosphorylation of the retinoblastoma gene, and you wind up with cell proliferation, angiogenesis, the ability to create a new blood supply in that tumor that's going to allow it to steal from our normal organ tissues and actually survive. Metastatic breast cancer is actually going to develop in about 20 to 25% of patients who are diagnosed with early breast cancer, although that number is beginning to change with all of the advances that we've made. There are patients who present to me with breast cancer, and they're found to be stage 4 at the very, very first day of diagnosis, and that's called de novo metastatic disease. 76% of patients will have hormone receptor positive and HER2/neu negative breast cancer. 61%, that's 2/3 of patients. And we'll talk about what that means to be HER2/neu negative and HER2/neu positive and how it plays a role in hormone sensitive breast cancer. We have lots of endocrine therapies for breast cancer. So when I tell a patient that we're going to treat her with hormonal therapy, they say, "You're not going to give me estrogen, are you?" And I say, no, I'm going to give you something that hopefully is going to interfere with estrogen finding a rogue breast cancer cell and helping it grow. Tamoxifen, which has been around since the mid-1960s, it was designed as a morning after pill, an abortion pill in the United Kingdom. And I can tell you that in that environment, anything that's related to abortion was not going to fly, and that drug was shelved. It was in the early 1970s that Jordan actually took the drug and looked at the anti-proliferative effects. If it could kill a fetus, maybe it could kill other hormone-sensitive cells, and that's how it was introduced in the breast cancer environment. And this drug was really reinvented. It became the most important drug from the 1970s, not only to be used in metastatic disease, but also in an early setting to prevent metastatic disease, as well as chemoprevention to prevent the development of breast cancer in the patient who might be at high risk for developing breast cancer. Very important drug. We can find it in every third world country, and we can't say that about most of our drugs. These three that are grouped here, anastrozole, letrozole, and exemestane, are all aromatase inhibitors. So they actually block the enzyme that converts androgens and steroids into estrogenic compounds, a very important class of drugs in postmenopausal women. And fulvustin is an intramuscular injection that's actually a selective estrogen receptor down modulator. It actually takes that receptor and it flips it. So if we look at tamoxifen, it works by actually interfering with the coupling of estrogen to the receptor. Tamoxifen has one molecular difference compared to estradiol, so it's a saturation effect. All of that, tamoxifen is going to go look for those receptors. It's a lock and key mechanism, and it does not allow estrogen to hit that receptor, so there's no proliferation cascade. We know that the landscape for hormone receptor positive metastatic breast cancer has changed from 1977, looking at tamoxifen, 1995, look at how many years it took for us to be able to develop another very important drug to be able to melt down breast cancer. 1995 until 1999, in 4 years, 3 aromatase inhibitors were developed, and then fulvustin in 2002. It took another decade and a half before we got even smarter. When we talk about aromatase inhibitors, they actually interfere with the production of estradiol. The fulvustin that I told you about takes the receptor and flips it. And even though we're using all of these drugs, and you would think intuitively, if you have a fire and you pour water on it and the fire is smothered and goes away, you may have some smoke, that we should be able to blunt that disease and make it go away. Yet cells become resistant because there are other parallel pathways that exist that we've just begun to come to terms with over the past half-dozen years. And we know now that there are growth factors that stimulate tyrosine kinase pathways, that phosphorylate AKT, mTOR, and eventually, but even though we've blocked all of these mechanisms from estrogen, these tumor cells are smart enough to become activated and do the same thing that estrogen does without using estrogen. This is a Circos plot, and we started to develop this blueprint about 10 years ago. It's become a mainstay in the oncologic community. And what this basically does, it looks at the actual blueprint of the genome in a patient and looks at its genome in its cancer, and by comparing the two, they are able to find out where the mutations occur. And if those mutations are identified in a patient, we can then target those mutations. And we have studies now that have looked at patients with estrogen-positive breast cancer that have actually identified in 40% of these patients one of those parallel pathways that I was talking about earlier, as well as p53, MAP kinase, in about another 10%. And this is all developing as we speak. And you know, it cost about $1 million to perform this blueprint about 15 years ago. Then about maybe 7 years ago, the cost came down to about $10,000. Now we could do it for about $1,000. The issue is, who do we do it in and what do we do with the information? And you always want to run a test when you have something to do with the information. Well, by identifying those mutations, by being able to identify those mutations and see that they may impact on that parallel pathway, we've actually developed inhibitors to, number one, the most important pathway that causes the cell cycle to go forward. So you have the cell cycle, and you go from G1 to S phase, and you have an abnormal cell. That cell should be able to be taken out at that point in time and not move forward in the cell cycle. Yet, if there's a mutation in cyclin D and CDK4/6, that cell will continue moving forward and doubling and doubling and doubling. And if you think of a checkerboard and just look at all the squares on a checkerboard, and you take one cell and on the next box you make 2 cells and then 4 cells and so on, by the time you get to the last box on that checkerboard, you will have trillions of cells. I always tell patients to look at their pinky nail. Look at your pinky nails. Do you see the size of your pinky nail? It's about 1 centimeter. You need 1 billion cells to be able to see a tumor that's the size of your pinky nail. If you have 10,000 cells, if you have 500 cells, if you have 1 million cells, you won't be able to see it. Not on any imaging and certainly not in any blood tests, although now we're developing blood tests, and I just put another patient on yesterday trying to see what is it about patients that have not developed a cancer versus patients who have. What is it that may be circulating in their bloodstream that may give us a clue as to how to jump in early on before the cancer develops? That's really exciting. It may not benefit that patient who gave me 8 tubes of blood yesterday, but it's definitely going to benefit her daughter. So now we're able to block some of these parallel pathways, and we've been able to see some of the benefits compared to just using anti-estrogen therapies alone. I'm going to go over this very, very quickly. These are clinical trials that have looked at randomizing patients to single-agent anti-estrogens and combining it with one of those inhibitors of the parallel pathway. You can see that those patients had a significant survival compared to patients who got single agent alone. So just by blocking that parallel pathway, we were able to see an improvement. Now, that's fine, and we're excited about it, but we'd like to get to a place where we're not dealing with metastatic disease. And now there are clinical trials looking in the early setting that instead of just giving a patient tamoxifen, just giving a patient an aromatase inhibitor when they're postmenopausal, or ovarian ablating a young patient with aromatase inhibition if they have high-risk disease, that maybe we should be thinking of some of these parallel pathways early on. And there are women who have signed up around the country, around the world for these trials, and because of them, we're going to have more information in the next couple of years. And the trials are exploding everywhere. This is looking at the mammalian target of replication, the mTOR inhibitor. You can see that there are multiple trials going forward, all of them exciting, looking at improvements in benefits, and these are all metastatic trials. This is the one trial that's in an early breast cancer setting. It's only a phase 2 trial. Eventually this will move forward to a phase 3 trial, and you can see that there is a trend to a significant p-value there. When I talked about that area that can bypass interfering with the estrogen receptor, I mentioned cyclin D and CDK4/6. This is the key right here, because no matter what happens up here, whether it's estrogen that's going to couple up with the estrogen receptor, whether it is HER2/neu being activated and triggering PI3K or AKT, every one of these factors are going to stimulate these processes, and you are going to wind up with cell proliferation. I made this on an airplane, so if it looks a little funny, you have to forgive me. But there are a number of trials that are moving forward. We now have approval for a very exciting drug, and it's being followed by 2 more drugs that actually inhibits that particular pathway. And we're seeing patients who have not responded to their endocrine therapy when it's given as a single agent now having huge responses in the metastatic arena when we couple it with this inhibition. And these are just 4 trials that have moved forward. Paloma 1, Paloma 2, Paloma 3 has been very exciting. Now the Mona Lisa 2 trial with a new drug called ribociclib has moved forward. All of these lend themselves not only in treating patients with advanced disease, and these drugs are not just on clinical trials, they're available to our patients right now. They lend themselves to being looked at in the early setting. It's much easier to treat someone early on when there's micrometastatic disease instead of bulky tumor loads. So again, if we are able to interfere with all of these parallel pathways, interfering with estrogen feeding these receptors, then perhaps we can actually melt down the process of cell proliferation. So the landscape now has further increased. We now have combination endocrine therapies with mTOR inhibitors as well as CDK4, CDK6 inhibitors with single agent endocrine therapies. And this is what I was talking about when, and I won't have George come up again, when we look at some of these mutations and molecular abnormalities and you look at a chromosome, you can have gene amplification, you can have a point mutation, you can have relocation of one of the base pairs, and you can have an abnormality that's just going to skyrocket. And we see this in patients who have a genetic mutation that predisposes them to developing breast cancer, ovarian cancer, and other cancers with BRCA1. And we certainly see it with PTEN. But one of the very, very important things that happen is looking at HER2/neu positive breast cancer, which we can see in estrogen negative breast cancer as well as estrogen positive breast cancer. And it really opened up the doorway to us about 20 years ago, and it was really exciting because I can proudly say that I was at the very forefront of this research. By being able to extend the identification of biomarkers in breast cancer and looking at HER2 amplification, we were able to open up a doorway and improve what we were offering patients by way of targeted therapy. I won't belabor this, most of you will know this, and you can see that there are 4 HER family members. The one that gets us into trouble is HER2. Every one of these has a natural product that stimulates them in order to cause proliferation, but they are weak on their own. Right here, HER2 has no natural ligand. We always said that somebody was going to go and receive a Nobel Prize if anyone identified this ligand, but there is no ligand binding activity. Think about HER2 as it being in an open conformation at all times, ready to partner with anyone. And once these family members are excited by their ligand, the hookup happens and they come together, and then HER2 will wake up all of these pathways that are again going to wind up proliferating at a very fast pace, these cells. Every single normal breast cell has HER2 expression on it. But if you think about it, George, I'm going to ask you to come up again. Stella, I'm going to ask you to come up again. Okay. And I'm going to ask Stella to stand right there. George, you're going to stand right. I'm a grandmother. We're bossy. You're going to stand right there, and I'm going to stand right here. So Stella, if you lift your left arm, just your left arm, and I lift my right arm, and we don't move our feet, can we touch hands? Oh, come on, let's try. No, put your hand down. It's always the male hormone that gets us into trouble. No, we can't touch hands. So this is a normal breast cell with normal HER2 expression. Now, if all 3 of us raises both arms, okay, both arms, this is a cell that has an abnormality in the genetic makeup. They have too many genes. They're amplifying that process. And now can we hold hands? Yes, we can hold hands. And when that happens, these cells excite those signaling pathways inside of the cell. Thank you, guys. And this is what we're trying to make sure that we can interrupt, getting in between those hands. And that research with these HER2/neu positive breast cancer cells, my daughter, who's got to go to my 3 grandchildren. You know, I'm going to say before she leaves, I have learned to be a better mother and wished I could have been a better mother to my daughter by watching what an outstanding mother she is to her children. And if I could have re-raised her with the gifts that she gives to her children, not only would I have been proud accepting this award, I think I would have been proud being able to say I was a good mom, because she's a great mom. I love you. So this is a HER2/neu overexpressing breast cell. This is the most aggressive subtype of breast cancer that exists. Not triple negative, HER2. Except we've solved it. We've solved it because by learning to interrupt those arms from getting together, we've been able to eradicate most of this disease. This is a woman who in 1993 had metastases around her mastectomy scar. You can't see it all that well, unfortunately, but we biopsied her. She had HER2/neu positive breast cancer. She was treated with a vaccine that interfered with those hands coming together, a vaccine. No hair loss, no bone marrow suppression. Her disease in 1994 was completely eradicated. She never received radiation therapy, all right, and she stays free of disease to date. So the antibodies were discovered. Their mechanism of action was to inhibit these receptor-receptor interactions, but we've gone so much better. We're not just using one antibody now. We've discovered second antibodies that we partner together. Women are not dying from the disease. We're able to melt it down even when they're stage 4. Yes, occasionally we will lose a patient. Just like with a heart attack, occasionally we will lose someone who succumbs to their cardiac event, but most patients aren't being saved right now. I don't go to funerals that often. ER-positive resistant cell lines, what happens when the actual receptor for estrogen becomes mutated? Then we have a whole host of issues because no matter what we do, that receptor is going to be turning that cell on. We actually have clinical trials that are looking at this particular issue, and they are active in these mutated cell models, and there are clinical trials that are ongoing. But breast cancer is a family of different cancers. Although we say breast cancer can be estrogen positive, it may be HER2 positive, it may be triple negative, meaning that it doesn't code for ER, PR, or HER2 we know that they act very, very differently when you look inside the cell. And we've come a long way with these estrogen receptor positive cells. We've come a long way with the very malignant HER2 positive cell. But what about triple negative breast cancer? What about triple negative breast cancer? And we know that they differ on the inside too. And we know that we treat these patients with chemotherapy. We try to look for targets, and actually a target has been identified in triple negative breast cancer that is already in the adjuvant setting in clinical trials. Because if you look at this very busy slide very carefully, and you look right here, that AR means androgen receptor, and 17% of triple negative breast cancer cells have been found to carry the male receptor for androgen. How are we treating these patients? With an anti-androgen. This is a patient who was 55 years old. She was diagnosed with a stage 2 triple negative breast cancer. She had appropriate surgery, aggressive chemotherapy, radiation therapy to sterilize the breast. And 2009, she has a recurrence in that same breast, as well as a lymph node now that's positive on the other side. She's treated with 1 chemotherapy, 2 chemotherapies, 3 chemotherapies, 4. She's now gotten 5 different chemotherapy regimens in the metastatic setting, and it's not going away, so she undergoes a mastectomy. The disease is pretty significant in that relapsed breast. She has a 7-centimeter lesion, 3 positive lymph nodes, and immediately she has new disease in that chest wall. And you can see it all here. Can you see it back there? Do you see all this here? She's now treated with more chemotherapy. So now this woman has gotten 7 lines of chemotherapy. And she's biopsied, and she's found to have the androgen receptor. So we treat her with an anti-androgen that we use in male prostate cancer with Casodex. And she had a complete remission after seeing all of this. So when I hear triple negative, oh my goodness, it's not oh my goodness. We're just getting smart enough to be able to understand the targets. So treatment decisions are driven by both prognostic and predictive factors. We know we have Oncotype right now that is used early on in early stage breast cancer, and actually some in situ breast cancer to decide on radiation or not. There are lots of models. One of the most popular models is the Oncotype test that looks at 21 genes. 5 are control genes. The other 16 are the assessment genes. And if it's a low score, these patients do very well. And you can see in this green solid line versus the dotted line, these patients in this low-risk group did very well and didn't need chemotherapy. Chemotherapy added nothing to their survival benefit. But if the patients have a very high score, then chemotherapy does have a significant role. And these are patients who had a high recurrence score. They got tamoxifen alone. They had a small tumor, negative lymph nodes. but with a very high recurrence score. No matter what we did with anti-estrogens, you can see here that their mortality was compromised. So there are multiple DNA microarrays that are out there right now. Oncotype is really the one that has been validated as level 1 medicine by NCCN and ASCO guidelines. I'm actually getting to the end. This is inflammation in cancer. Remember when I mentioned the immune system early on? Well, cancer does not work alone, just growing in a particular environment. It takes advantage of our own immune-based cells, and it eventually will allow these cancer cells to secrete products to turn the whole cascade of our immune surveillance against the cancer cell and actually work for it. And these tumor cells do secrete products. They saturate the T cells. There's PD-L1 and PD-1. This was well documented in the melanoma group. And now we're looking at it in triple-negative breast cancer. And we know that if we can vaccinate these patients and stop this immune-carrying cell from favoring the tumor cell, that we can actually get rid of disease. Obesity and breast cancer, we're Greeks, we love to eat. I know of women who have told me on multiple times when I would give talks in church basements that they can't afford a mammogram, yet on Sunday afternoon dinner, there's no less than 3 different meats on the table and exquisite appetizers. You know, it really is astounding to me, because for 25 years, for every report that came out that said obesity is a risk factor for breast cancer, there was another report that said, no, well, now we have the data, it's gone to Washington, and the way you see smoking is a hazard to your health. Those same placards are going to be around the country stating that obesity is a risk for developing breast cancer, not only developing breast cancer, developing recurrence. We know that there's increased insulin resistance, we have increased estrogen levels, and the most important thing is that we develop these crown-like structures in our breast cells from the activation of aromatase. Because the more fat we have in our breast, the more it's going to secrete aromatase. That's going to trigger our breast cells to actually develop these crown-like structures. And we know patients who have an increase in these crown-like structures have a lower survival down the line. And so this data has already moved forward. Actually, your very good medical oncologist, Neil Iyengar and Cliff Hudis, have been champions of this research. It's ongoing at Dana-Farber, out in LA, clearly at Memorial, and we are looking at this seriously. There are trials right now that are randomizing patients to chemotherapy versus diet and lifestyle changes. When a patient comes to me who I've treated for triple-negative breast cancer, and they say to me, Dr. Theo, what are you going to do for me? You're giving Herceptin, anti-HER2 vaccines, to my one neighbor. You're giving tamoxifen to my other neighbor. What are you going to do for me? And then I say, we're partners in this. Get out there and exercise. Decrease your calories. It's so bizarre that that is the subtype, ER-negative, PR-negative, that actually responds to caloric decreases. So obesity and breast cancer, the trials have been done. It's out there. It's gone to Washington. We know that medicine has moved from the way we did radical mastectomies in the early 20th century, not only removing the breast, but the underlying musculature and all of the regional lymph nodes. It was very disfiguring to what we started doing about 15 years ago at Memorial, and this is a patient who had a mastectomy and a reconstructed breast. She got a tummy tuck at the same time, and you can see that in the 21st century, our surgeries are so different. Well, what do we mean? That it's a bit muddy. We have parted the waters, but it's still muddy. We haven't gotten to the other side. I truly, truly believe, and that's why I could never retire, that I'm going to see it in my lifetime. And I need to see it. I need to believe it. And that's what I do believe when I go to work. So for all of the physicians in this room, we learn every day from our patients. They educate us and they volunteer for clinical trials and they teach us. And for any patients that are in this room, remember that that word patient, patent, only exists in your mind if you think of yourself as a patient. And that's it, guys. Thank you so much.
In our panel today, her name is Maria Georgiadis Fagianos, and she's assistant professor of surgery at Hofstra North Shore LAJ School of Medicine. She's also the associate program director for the Surgical Critical Care Fellowship at the Department of Surgery, Trauma, Acute Care Surgery, and Surgical Critical Care at North Shore University Hospital. Without further ado, Dr. Maria Fagianos.
That was an amazing, amazing talk. I learned everything that I needed for breast cancer. It was a nice review for me for my board certification in like 8 years. And honestly, you're such a great role model for female physicians like myself that you motivate me to be better every day. So it was great.
Where's my daughter?
So today I'm going to be talking basically about trauma resuscitation. I have no disclosures, but I do warn you, some of my photos can be a little detailed. We're going to go over a case presentation that actually is very dear to my heart. We're going to talk about trauma resuscitation, massive transfusion protocols, whole blood versus component therapy, tranexamic acid and hemorrhagic shock, and something called damage control laparotomy. So it was a beautiful summer day. I was hanging out. It was kind of quiet in the morning. All of a sudden, I hear a helicopter, and then a pager goes off. They bring in a 29-year-old female that basically was in a propeller accident. She was going to get a floating device. Somebody started the boat. Her leg got caught up in the propeller. She complained of severe lower extremity pain. She had altered consciousness on the way to be transported. Luckily, the Suffolk County Marine group was actually doing their exercising run, so saw her in the water. They actually didn't have a radio on the boat, and then brought her to the beach. And then the Nassau County Air was actually doing their runs and went and transported her to us. So she got to us within 1 hour. So in the trauma bay, she had altered waxing and waning consciousness. We secured her airway. She had extensive soft tissue injury to bilateral extremities and the perineum, bilateral pubic rami fractures. Her right lower extremity did not have a pulse. We initiated a massive transfusion protocol and emergently took her to the operating room. Here you can see everything is completely macerated. Here is her some fascia, and here's her muscle. Her femoral artery and vein are obliterated. Here's basically her vagina and rectum and perineal area. Here is holding up the lower extremity part, the leg. You can see over here that the muscle is hanging out. So the start time of the operation was around 1:30 and finished around 8:30. She had a deep degloving injury of the right lower extremity. She ended up undergoing, with the help of vascular surgery, a right superficial femoral artery to above knee popliteal bypass, when we used her saphenous vein as a graft, and we also underwent fasciotomy. She had injury to her perineum, and urethra, and vagina, and with the help of urology, we placed a suprapubic tube. So here you can see the musculature. The propeller literally cut in the center of everything. And here is basically the repair. So here, this is an example of the common femoral artery with the saphenous vein graft to the popliteal, but her injury was really in the superficial femoral artery. We were able to find the popliteal artery right above the knee, and then basically take her saphenous vein graft and reconnect it. At the point of massive transfusion, she had 3-liter blood loss. She got 3 liters of crystalloid, 18 units of packed red blood cells, 13 units of fresh frozen plasma, 2 units of platelets, and 5 units of cryoprecipitate. Post-op day 2, she underwent a cystoscopy, a Foley placement, debridement of her right lower extremity, and post-op day 4, more debridement. She basically needed constant debridement in order to get take away all the muscle that was necrotic. Finally, on post-op day 5, unfortunately, we had to do a right hip disarticulation on her because it was infected, and I'll show you guys pictures. She needed 37 units of packed red blood cells, 29 units of fresh frozen plasma, 7 units of platelets, 25 units of cryoprecipitate and biobulin, 99 units of blood products. So this is her wound, as you can see. There are some parts of granulating tissue, which is healthy tissue, but obviously it has this infected look. There were multiple times that we had put antibiotic beads with orthopedic surgery in the area in order to help and clear up the infection. And here is the VAC dressing, which helps with blood flow. It increases nutrients to the area and takes away debris and helps wounds heal faster. So basically, trauma resuscitation. Hemorrhage is the etiology to cause some mortality in about 30 to 40 patients. Fluid resuscitation is basically aimed at continuing to have perfusion to your vital organs. We use permissive hypotension strategy because you don't want to bring up the blood pressure so much to increase your bleeding. And so you want to keep it low enough where you're not going to have a cardiac arrest, but at a point where all your brain, cardiac, kidneys, everything is perfused. There are multiple research studies demonstrating that actually over-resuscitation could be worse. There's increased bleeding, coagulopathy, acidosis, and it causes an exaggerated inflammatory response. Crystalloid resuscitation, when a trauma patient used to come in, it used to be 2 liters instantly. It was hung. But the American College of Surgeons recently has amended that to 1 liter, and we use now, instead of aggressive resuscitation, we use the balanced resuscitation. So that overall gives enough fluid and blood products to perfuse your organs, but it avoids any circulatory overload. And then it basically tempers any risk of rebleeding. We do consider, as this is used for all adults, we do have to consider vulnerable populations like the elderly and trauma. They have more cardiovascular disease, they're on hypertensive meds, and more importantly, they're on anticoagulants. The Coumadin, Eliquis, Pradaxa, Xarelto, all those increase the risk of hemorrhage. Luckily for Coumadin, now we have FDA-approved Kcentra to reverse coagulopathy, and for Pradaxa we have Praxpines. But for Eliquis and Xarelto, we have nothing. So therefore, and my population is about 80% elderly. So I see a lot of head bleeds and traumatic injuries and pelvic fractures from accidents with these agents. We do talk about the golden hour, which is the first 60 minutes after your trauma, in which you have amount of time of trauma resuscitation, and that gives you the most benefit to your therapy to actually give you increased risk of survival. But it doesn't mean that you only have 60 minutes to survive. So we use massive transfusion protocol. It's packets that are packed red blood cells, plasma, and platelets, usually in a 1-to-1-to-1 ratio. Given this, there have been studies that looked at massive transfusion protocol, and they looked at giving freely blood products and then doing a formal damage control resuscitation. And what they found, even though they had some variability in terms of the MTP, depending on the surgeon and who gave it, they found that giving a formal damage control resuscitation actually improved survival, decreased the number of blood products, and also had increased cost savings. Overall, doing a massive transfusion protocol in a formal way reduces hypothermia, minimizes your crystalloid use, and prevents any, and gives you modest hypotension. So how is it defined? There's actually multiple definitions out there in the literature. It could be the replacement of your entire blood volume in 24 hours. It could be greater than 10 units of packed red blood cells in 24 hours, greater than 20 units of packed red blood cells in 24 hours, greater than 4 units of packed red blood cells in 1 hour when there's ongoing need. And then it could be a replacement of 50% of total blood volume within 3 hours. All this says is you get a lot of blood because of this. So before, in the 1970s, we used to use whole blood as a resuscitation fluid of choice. But due to the the increased time that it would need for storage, then they went toward a crystalloid-based resuscitation practice change. And that led to dilutional coagulopathy. So then we noticed that the platelets, fibrinogen, and important factors like 2, 5, and 7 had decreased due to this, causing more bleeding. The targets of a massive blood loss resuscitation, you want your MAP greater than 60. You want your systolic blood pressure at 80 to 100. Your hemoglobin should be 7 to 9. Your INR ideally should be less than 1.5. And your PTT should be less than 42 seconds. Your fibrinogen should be greater than 1.5 to 2. Your platelet should be greater than 50. Your pH should be around 7.35 to 7.45 for homeostasis. And your core temperature ideally should be greater than 35, and your base deficit less than 2, and lactate less than 2. So the best ratio for transfusion products has been debated. In 2007, Borgman et al. Published a landmark study that looked at the role of balance of transfusion therapy in combat casualties, and basically looked at plasma ratio to packed red blood ratio of 1 to 1.5, and noted there was increased survival to that. Then in 2015, there was another randomized clinical trial. They looked at two ratios, 1 to 1 to 1, 1 plasma to 1 platelet to 1 packed red blood cell versus 1 plasma to 1 platelet to 2 packed red blood cells. And they basically looked at the results, and there was increased survival in patients within 24 hours and 30-day mortality in the 1 to 1 to 1 ratio. So if you give equal blood products, you will have increased survival in those patients. It also decreased the exsanguination rate in the 1 to 1 to 1 ratio, where it was 9 patients survived, had decreased exsanguination versus 14%. Then we looked at the amount of blood products that they actually received. There was actually less in the 1 to 1 to 1 ratio for hemostasis. And finally, they looked at preemptive complications, and they saw that in the 1 to 1 to 1 ratio, ARDS, venous thromboembolism, and mortality was decreased. So then we looked at whole blood versus component therapy, and in the United States, for the most part, component therapy is what we give. They're universally compatible donors. They basically type in screen, and then they give it. We can, initially when a trauma comes and is in hemorrhagic shock, I give them 2 units of uncross matched blood, and then I ask for my massive transfusion protocols. But by then, the type in screener is already sent and run, and they give type blood to my patients. Whole blood, though, is overall has all the individual components and comes in one bag, and you would think that's more efficient. It basically reduces the amount of hemostatic, non-oxygen carrying fluid, and it's usually uncrossed O positive is what they look for. They did a study looking at, they gave 2 units of uncrossed O positive whole blood, and they basically followed patients, and there was no temporal relation to any side effects and transfusion reactions in those patients. So basically, there's no difference in giving whole blood in terms of reactions. There's also tranexamic acid that has come. Basically, fibrinogen is a critical precursor in your clot formation. So you have excessive fibrinolysis, and then you basically have fibrinogen consumption. Tranexamic acid has been an antifibrinolytic, where it basically is a competitive inhibitor that decreases plasminogen to plasmin, and plasmin breaks down your clot and your fibrin. There was a CRUSH-2 trial, and basically the result of that using this agent decreased the reduction of mortality and also decreased the death from hemorrhage. So some hospitals do use this. My hospital doesn't, but there's been talk about starting to use it. So you think about, whenever you're in a trauma situation, you're like, what's my next move? Having all these massive transfusion is basically, you want to prevent your triad of death, which is coagulopathy, hypothermia, and metabolic acidosis. A lot of times I have people bleeding to death, and they come in hypothermic to me, which increases their coagulopathy, and then they have decreased perfusion, which increases the lactic acidosis and metabolic acidosis. So I need to get these patients off the table fast. So a lot of times I don't have the time to close them. So what we do is we pack the abdomen, and we also put something called an ephthera, because their bowels are so dilated from all the blood products they receive. So this can be a sign of not being able to close the abdomen. And then this is something called an ephthera, in which is basically a dressing. So let me show you. This is bowel. And basically you put the ephthera dressing over, and it takes away any fluid and sucks it out over the next, whenever you take the patient back to the operating room. It could be the same night, it could be in a day or two. And you want to take the patient back to the operating room as soon as they're hemodynamically stable. They're off their vasopressors. They're able to go back. Their coagulopathy has ceased. So, any questions?
I'm going to ask a question for both of you. And many times, not everybody in the room is a doctor, but everybody probably has similar questions. You're the expert. I'm just curious, how do you live your life? So the first question to you is, Maria, I'm just curious.
We're both Marias.
The first question to you is, when you see a blood bank, do you feel the need to donate, given what you see, or is it not all it's cracked up to be, or is the wave of the future? Can you tell us something about blood donations that people, even lay people, should know, or perhaps we don't want them to know, but the reality of blood?
You know, I don't donate, only because my veins are so tiny that nobody ever finds them and I get bruised constantly. I should donate. And there's nothing hidden. I mean, they may use whole blood at some point. It's not the choice right now. We definitely use component therapy, but there's no, I mean, they just go and give blood and they give you like a drink or juice or whatever. I don't think there's a wave of the future and a different way to get blood. Right now, the standard is donation of blood, and honestly, everybody should be able to donate if they're able to. That's how we build our blood banks. That's how we help our patients.
Well, the question to you is perhaps twofold. One, everybody or many people are talking about mammo versus, forget about the change in the United States Preventative Health Task Force, but mammo versus mammosonogram. And it's not uncommon, that my wife might say, so-and-so gives everybody mammos plus sonos.
That's actually a great question.
What is your take on that?
So it's basically individually based. It's based on the density of the breast. It's based on whether mammography actually can get a good look at what the field is. If the breast is dense.
But when the breast is dense, even the mammographer says you need a sonogram.
It depends on where you are. Maybe in New York City, yes. Or even in the regional areas, but not everywhere. And we really have to sensitize our physicians, because that report's going to go back to the primary care physician. And the primary care physician should not just be filing these reports because they say benign, BI-RADS2. They should be reading it and helping the patient make some decisions if they aren't getting further studies beyond mammogram. I'm a big believer in young patients, and young meaning premenopausal patients having ultrasounds with their mammogram. Most of those breasts are dense. But again, we can make those decisions based on the baseline. You can have a mammogram and an ultrasound done, and if there's a palpable mass, that doesn't mean everything is okay because something doesn't show up. All right, so again, it's very patient selective, and we should be able to guide our patients. And unfortunately, it's an educational process and I throw it back to the primary care physicians and the gynecologists.
Well, that was a truly riveting Mary Kalopothakis symposium with Dr. THEODOULOU and Dr. Sfakianos giving really riveting, entertaining, and touching talks on their specialty. I hope everyone learned something. I know I did. And thank you to NGTV for always being there with us and celebrating these times together. Thank you.
MGTV USA. Οι δραστηριότητες της ελληνοαμερικανικής κοινότητας με βίντεο και πλήρες ρεπορτάζ. Επισκεφτείτε την ιστοσελίδα μας mgtvusa.com. Καλύπτουμε καθημερινά τα γεγονότα στην ομογένεια.